Refreshed. We're so pleased to welcome everybody to the second day of the Wisconsin Cancer Collaborative Summit. I'm Melinda Stolley. I serve as the chair for the Wisconsin Cancer Collaborative. Before we get started, just a few housekeeping details. If you could all please change your name to include your organization, that would be great because that will help with our networking later, which I will do right now. I'm with the Medical College of Wisconsin, professor and associate director for cancer prevention control. And I hope that everybody was also able to attend yesterday. We had a fantastic day learning about the state plan, hearing from Dr. Lisa Richardson. And today, I'm so excited about today because I think it's really a time to focus on our health equity chapter and think about how we're going to implement some of these changes, social changes, in our own work and our own lives. The summit today is really this great opportunity to come together and think about not only equity, but how we're going to implement the plan. So one thing to know is that as you are going through the day, it's important to think about the chat and that you can put questions and post your comments there. Our agenda is that we will have Ginny Finn speaking with us. There'll be a short transition after that. Then Dr. Staci Young, a break. And then we have our regional meetings, which is this great opportunity for us to be talking with others in our region. Granted, all of this is new to be doing this virtually as opposed to in person. The meeting yesterday went fantastic, and I think we really want to applaud the staff of the Wisconsin Cancer Collaborative for putting that together, and also the day for what's going to go on today. So the focus today, let's change slide to the purpose, please. Oh. Okay, so the purpose for today is really to learn about the drivers behind health disparities in Wisconsin. And as I said, this opportunity to think about how to work towards equity. Our speakers are fantastic, knowledgeable, experienced, really experts in the area of equity and leading organizations whose missions focus on this. Next slide, please. I am so pleased. Ginny Finn is one of the first people actually I met when I came up to Milwaukee. She is an amazing person. She used to lead ABCD. But today, now, she is the president and CEO of the YWCA Southeast Wisconsin, and they are so lucky to have her. Ginny leads the organization, their strategic communication development efforts, and she also works with the board of directors and leadership to reimagine sort of this expansion of gender and racial equity work and related collaborations. And I think we're all well aware of the tremendous work that the YW does really across the nation related to equity, gender and racial equity. She's an attorney with 25 plus years of consulting experience. She practiced healthcare law at Michael Best and Friedrich LLP for nearly a decade. God, I don't think I knew that about you, Ginny. You're so likable. And then she served as the executive director, as I said, for ABCD after breast cancer diagnosis, which is a Wisconsin-based national breast cancer survivorship service organization. She currently serves on the board of directors for IBC Network Foundation, the National Breast Cancer Coalition, LIFT Incorporated, she's busy, a youth development field hockey program, I did not know that about you, and Ascension Wisconsin's IRB. She also co-chairs the Medical College of Wisconsin Center Advisory Board. I think all of that reflects the tremendous commitment she has to service and to equity. And with no further ado, I will turn it over to Ginny to start our day towards equity.
Well, thank you, Melinda. And certainly that is more ado than I deserve. And I do want to correct, there apparently was a typo in there. I did not practice at Michael Best for 10 years. Rather, I was at ABCD for almost 10 years in that particular role. Although I'm really gratified that I've actually been part of ABCD since its founding in 1999, first as a volunteer and then joining the staff, because actually my volunteerism and my professional work that touched healthcare was basic training, if you will. And then the world at ABCD taught me much more about cancer. And that's why one of the reasons I'm delighted to be here today. I also want to thank everyone at the Cancer Collaborative, many of whom I've known in different roles over the years, for the opportunity to share some reflections with you this morning. And I do so from my office at YWCA in Milwaukee. We are an essential service and so have actually never stopped working, although most of my colleagues are set up to work remotely. But it also is true of YWCA that we serve the southern corner, about 5 counties of the state. And that makes us very mindful just on a day-to-day basis, as I'm sure many of you are, that we live in a state of extraordinary beauty, but also a state that was home to people long before Northern Europeans arrived. And so I do want to respect the fact that as we speak of equity today, we remember as a first matter that not only are there a number of tribes in Wisconsin, both currently and those that are elsewhere now, but there are 11 that are recognized as independent nations that are based here in Wisconsin. And because of our past history in building this nation, we do have Indian communities and tribes that actually don't exist, or certainly don't exist as they once did. And I think reflecting on our history is kind of an underlying theme for this morning. So before we get into the meat and potatoes, they always tell people what they're supposed to take away. So in case they fall asleep while you're talking, they actually remember something. So my 3 takeaways are pretty basic. And it really speaks to those of you who are in cancer professionally, whereas I am simply an active volunteer. I am not a clinician. And although I am trained as a healthcare attorney, financing a hospital building is not the same thing as taking care of patients by any stretch of the imagination. But I have always been impressed by healthcare overall and cancer in particular, in that there's a commitment to looking for a root cause, and that a root cause analysis and continuing to ask, why is this so? How can we get to a different outcome? That is a standard cultural thing for people in oncology care. So when we reflect on race, racism, and health equity, it's really adapting and adopting that value of a root cause analysis and constantly asking why that is important. Another takeaway, which is not specific to this presentation, and I'm sure many have heard before, but is something to remember in the context of the information that follows: equality is not a synonym for equity. As the plan clearly states, it is the equitable outcome that is the plan's goal, not an identical process. And then the third takeaway really is that everything that was spoken about yesterday, as well as we'll talk about this morning and the rest of today, ties to priority 1 of the plan. Although it has more than one priority. Priority 1, I think, really underpins this morning's conversation on equity. And that is the stated priority is to increase the capacity of the burden of cancer, increase the capacity so that we can reduce the burden of cancer on everyone. And that's why the equity conversation is important. Next slide, please. So tying these remarks to the cancer plan, I'm not going to read the slide to you, but these are the overarching goals that are specifically cited in the plan that you all have. Certainly, the last item, improving the quality and use of cancer-related data, is often an entry point when we talk about equity, because we like to collect data and we like to collect information that is data. as opposed to something that's qualitative. And I'm going to get to the qualitative, quantitative conversation in a little bit. But when I think about how health equity is impacted by race and racism, I think it's not only a conversation, but it's an ongoing reflection that we can't skip over if these overarching goals are to be met. And in particular, as reflecting on race and racism in any context can be difficult, and quite frankly, difficult for white people. Keeping these overarching goals as a grounding matter, I think, could be really helpful. And I will reference just slightly about my comment about especially white people. We are kind of touchy, shall I say, in this country when we want to talk about race or racism. Some of us embrace the terminology comfortably, with great comfort. Others shy away from it. But the reality is we have inequitable cancer outcomes. And so if we are really committed to a root cause analysis, we must be willing to have these conversations, have these reflections, and come back to them time and time again. Next slide, please. So my lawyer world will come back to haunt us this morning. In particular, definitions are really, really important. And so, as I mentioned, equity and equality are not the same thing, but equity, for the purposes of this morning's conversation, let's just make it a very simple definition. Equity is about fair and impartial. Again, it's not about equality, it's not about sameness or identicalness. Health equity, which is a definition I've taken right out of the plan, is the opportunity to attain one's full health potential. And as it happens, we're not all even born with the same health. So I'm sure that everyone can appreciate that the process of getting to that full health potential will not be identical. And health equity is further defined on page 10 of the plan as a process where we deal with preventable and unjust differences in the burden of disease, injury, violence, and opportunity. There is a link there to the social determinants of health and what the real world is all about. And someone I did notice also put a link to a similar article. Oh, it's actually the same length. Wonderful. That discusses all the various social determinants of health. And going back to the example of a root cause analysis, as we choose to read that article, and I'm sure many of you are probably intimately familiar with it, considering the question why constantly, about why are those social determinants different for different people. A couple of other definitions that I think are important, and there are those, especially in academic circles, who provide more layered or complex definitions. But I think for this morning, to provide some simple and direct definitions. First of all, is to understand that race is a social construct. It didn't exist until we created this construct. There is plenty of history, some of which is actually now finally taught in high schools, but wasn't really taught at least when I was a kid. And so that race as a social construct, the idea that we are distinct. If you're my age, you remember the words Caucasian, Negroid, and Occidental. Yes, they were very interesting words. They decided a long time ago in Western literature that there were three races. We obviously have a more nuanced understanding of race now, both that it was created as a social construct, but also because it's been a reinforced social construct, it does have a very real effect on our lives. And that effect can be different depending on who we are, where we live, and even all kinds of other social determinants of our lives. Racism, as distinct from race, has two parts in its definition, and it's really important because I think we often confuse racism and racist and other terms that are rooted in that word. Racism is a belief that there is a hierarchy in races combined with, and this is very important, and the power to reinforce that belief. So one can believe that there's a hierarchy in races, but racism is that system that reinforces that hierarchy. And we're going to get into how that's reinforced in a couple of slides. Privilege is another word that I think is really important to define, especially since in the context of talking about racial justice and other justice issues, the word privilege is often attached to a modifier. But I really like sticking with the simple dictionary definition. Privilege is a right or an advantage that is gained by birth, social position, or concession. Now, this privilege can be reflected in our structures and systems, and I'll touch on structures in a little bit, and the next speaker will actually be talking about healthcare systems in particular. But what's really important to understand about the definition of privilege, a definition that does not change in the context of racial justice and racial equity, is that privilege is never earned. So that's really important, I think, when one either is party to conversations or reads commentary or even hears it on the news about the term white privilege. As I mentioned many times, the word privilege has a modifier attached. And in current parlance, when the term white privilege is used, there are those that embrace it wholeheartedly and those that reject it. But I often find not everybody even agrees on what it is. So let's be clear. Privilege is a right or advantage that was not earned. That's the definition. Privilege is not earned. So white privilege, by definition, is not in any way dismissing the work that people do that earns them the achievements, the success, or even the health that they themselves enjoy. It simply means that by the virtue of being white, there was an advantage in our particular culture that wasn't there to those who are not white. That doesn't mean it's definitive of the end result. It's just one aspect of an entire experience. Another important definition for the purpose of conversation this morning is access. And that's particularly important because that word access is used constantly in the plan itself. And it's noted as the ability, right, or permission to approach or enter. And that can often be a literal ability, right, or permission that is imposed by someone on another, or it can be the perception of someone of whether or not he or she or they have the ability, right, or permission to enter. And in this case, of course, we're talking about entering the healthcare system generally and the oncology care system in particular. Next slide, please. So many of you may already be familiar with this resource, and if you aren't, I certainly encourage you to visit this particular link. Harvard has an implicit bias program that has been in place for a number of years, and it really provides one a baseline understanding of implicit versus conscious bias. I mean, as I'm sure everyone who's participating today already knows, this isn't new news that I'm sharing, that we all have biases. And some of them keep us alive. We have a bias in the United States to look left as we cross a street because we have implicitly been trained and now understand that that's the traffic that's likely to hit us first before we cross the street. But if we were raised in Great Britain, our implicit bias would be to look right, because that's how they have been raised, because that's where their traffic comes from. What's fascinating about the implicit bias website, not only the articles that are there and the articles that have sprung from it, but it has a number of tests that you can take. They're self-administered. Basically, you do have to cough up your email so that you can participate, although they, of course, pledge to de-identify information, etc. And then you can choose to take all kinds of tests. A number of them are specific to race or ethnic background, but there are also information regarding gender identification, age, which is really interesting. One of the things I learned about myself was my particular bias against teenagers. And I don't know if that existed when I myself was a teenager or is true because I am long from my teenage years. But I really think that if you have not ventured into that link, that you might find it really interesting as a point to start in terms of self-reflection, because understanding our implicit biases, by definition, the things we're not aware of or may have only basic awareness of, that's really important. Now that I've identified through this process that I instinctively walk away from large crowds of teenagers. It's not that I don't do that anymore. And of course, I'm referring to a pre-COVID life. Don't see a lot of teenagers at all right now. But I am aware when I did it last summer, why am I crossing the street? Why am I uncomfortable? And it really was helpful. Turns out I also have an implicit bias to prefer women over men. I could think of all kinds of reasons for that, but quite frankly, one of my lived experiences is to be one of 7 children, 5 of whom are boys. And those 5 were closest to me in age. And I grew up my entire life surrounded by what those boys wanted to do. And so I can certainly give you a litany of reasons as to why I have certain biases that may or may not be all that negative, but certain biases and assumptions about men. The other thing that's important about bias, in particular implicit and conscious, is that it does intersect with racism. And 2 terms that will often, I think, during the cancer plan's lifetime come across often are structural and systemic racism. And as I mentioned, the next speaker is really going to be talking about systemic racism in the health context. But I think for structural racism, one of the basic things for us to understand, it's a fancy pants academic word, but it means cultural, the things that are baked into our experience. And the reason that's important is the culture we grow up in, the culture that we take for granted, the culture that we are taught is the standard or the norm, is the soup, is the building block for how we build our systems, which is a fancy pants academic way of saying institutions. And so if we are unaware of the biases that are rooted in our structures or in our underlying culture, then it's harder to recognize when those biases might lead to either advantages or disadvantages as we build our systems and our institutions. And so one of the questions when it comes to talking about race, whether it's in a health equity context or not, that I always wonder about is, why are we so touchy? And who is we? And I think that comes back to, there's a certain irony about having a white woman speaking with you this morning about racism in the United States, because certainly we have hierarchical, structural, cultural, implicit biases that assume white value systems or value systems that have grown from a North American, European culture, primarily, if you want to be specific, a British culture, that those are norms, and questioning that those norms might not be the best or most effective for getting to where we want to be, and in this case, equitable health outcomes, that can be threatening, because I've grown up my whole life thinking certain things were normal and appropriate. And I can give a Midwestern example that surprised me recently through my book club of all things. So thank heavens for book clubs. I don't know if all of you are readers, but during this day of connecting with people via Zoom, it's been terrific for me to have the women I have a book club with to be part of a social life and be able to connect to other people. And a number of months ago, one of the women, after we'd read a number of serious books, said, I really thought something lighthearted would be great. So I have selected the biography of Laura Ingalls Wilder, who is the author of the Little House books. I'm certainly of a certain generation, and I'm a Midwesterner. And so I grew up reading those books, and people a little about my age, even if they hadn't read them, probably grew up watching the TV series, which those of us who read the books were mortified, were not actually faithful to the books, but that's another presentation. What was interesting about those books is I didn't really think about the fact that these issues of race and racism and structural racism would ever be touched on. And yet these books, like any good biography, told the story of the people that were subject of the story, but also the world around them at the time. And so in the context of each book, the author explained what was actually going on in this little girl's world. And the first book, Little House in the Big Woods, is actually set in Pepin, Wisconsin. And it turns out that the timing of that book and the Indian wars that are referenced in that book, and referenced in passing, obviously, since it was a child's book, were all started because we were busy, we being the power structure of the US government, relocating American Indian tribes so that settlers could move out and occupy lands in Wisconsin and Minnesota and then the Dakotas. And what was really interesting is that there was a chapter that talked about what was happening politically and how aware and unaware Washington was about what was really happening with the dislocation and relocation of Indian tribes, the hard winters, the subsequent starvation, the reason there were wars between the settlers and the Indians, which had much to do with the duplicity of the settlers, as if anything, if nothing else. And the legal acts that were created by the US government to make all this activity legal were actually a platform of a particular candidate who has become a revered president. And the initial relocation of the Indians, which led to massive death, starvation, and war, were actually the result of congressional action that were promoted by Abraham Lincoln. But I never remembered any about that from my high school days. What I remembered was the Emancipation Proclamation. So I think how we're taught history is part of the answer of why we, white people in particular, might be so touchy. But for those of us who are not white, we might be touchy because our own understanding of history, often taught at our kitchen tables rather than in schools, gives a much more nuanced picture. And then the final point is to return the root cause analysis. How do we apply that to racism? If that is a value about how we provide better cancer care, how do we apply that concept to how racism might affect cancer care? Next slide, please. I tell you all these stories really because I know that cancer conferences are often about data and studies and fancy charts. And as I discussed this morning's conversation with the folks at the Cancer Collaborative, really asked to stay away from that. So I'm sorry, there aren't fancy charts, and I'm not really good at visuals either. That's why you have bullet points here. But I really think this is about the power of humility and ongoing self-reflection. This is not about woe is me and guilt or anything like that, although I certainly can't tell anybody how to quote unquote feel. But I do think it is opening the minds of those of us, whether we are volunteers or clinical or medical professionals who live in a healthcare world, to understand that lived experience is useful evidence that we must consider as we do root cause analysis. And this is me again being a lawyer. Data is not a synonym for evidence. And this is kind of contradictory because yesterday morning we talked about, our two presentations talked about the love of data. And I am, in fact, a lover of data, although maybe not completely a data geek. But the reason I say I take a lawyer's definition of evidence is that, you know, if you've watched any court drama or have ever been on jury duty, you are well aware that evidence that will convict someone of a crime or actually in a civil court help a jury reach a decision includes circumstantial evidence, includes testimony and observation by other people. And as long as these things are corroborated under the rules of evidence in a court of law, they have the weight of data. In addition, all of you out there know the value of clean quantitative information, but we're living through a time right now where we're also seeing data manipulated and put in a context where it either isn't really telling the entire story or is being promoted as though it's relevant when it's not. So I do encourage you, as the cancer plan is developed and action items are evolve over its time period, to weigh lived experience and to take your own lived experience, as well as listening to the lived experience of patients and their families, as useful evidence as to how to build health equity into the systems. Also, I want to encourage, in particular, again, those of us who are white, just because my lived experience is this is a particularly cultural thing. We want to, when we see a problem, we want to rush out and fix it. And in fact, I gave a presentation last night to another group, and we talked about having been to a movie. And then after the movie, there was a panel discussion. And someone said, well, I really want to know what I can do in the next 6 months to solve this problem. This racial injustice is horrible. And that is a useful impulse, but learning is an action. Understanding the situation, in particular, listening to those who have lived experience to share, is an action. I do have some basic links there, and I do apologize that I don't have the link for The Immortal Life of Henrietta Lacks. Many of you are probably familiar with that publication, but those are very, I have found personally, through my lived experience, very valuable resources. I simply, being in the cancer world, I found The Life of Henrietta Lacks a fascinating book. Tears We Cannot Stop is simply a book I can tell you that if you have time to read no other book in the next few months, please choose to read it. Dr. Dyson is a fascinating author and speaker. He is a professor, I believe Georgetown, but I can't remember, as well as a Baptist minister. And so he takes his expertise from many different fields to weave an understanding of the world that he believes we live in right now in this country. And then there's another book by Robin DiAngelo, who's also a professor, called White Fragility. There's actually quite a lot of dialogue going on in the world right now about whether or not her concepts are completely legitimate or not. But I think it does discuss in a very handy way, and the YouTube link is a brief 20-minute introduction as to why we as white people might be unwilling to talk about race and racism, even as our colleagues, friends, and neighbors of color desperately want us to be able to have honest, constructive conversation. Next slide. So race, racism, and health equity. Just wanted to touch on the structural concepts here and how they might apply in Wisconsin as a precursor to the more formal system conversation you'll be having with the next speaker. So as I mentioned, structural racism, if you really think of it as culture, that might be a little less academic. But it really has to do with the assumptions that are so embedded in our culture that they become the implicit norm. We may not even be aware of them, which is why that implicit bias link can be so handy. And it's really important because the reason that academics use the word structure is because these assumptions are the structures that exclude substantial numbers of people. We often refer to these as minority backgrounds. From taking part in the actual social institutions. And interestingly enough, the professor whose definition I have quoted there, Carl Lee James, is actually a Canadian. So if we are ever misunderstanding the idea that race and racism is a concept that is specific only to the United States, it's not. Certainly all of our nations, different nations, have different variations on this. And they don't all have to do with the same colonial history that we have in the United States. But I do think it does underpin the idea that race and racism can be structural because it does root in culture. And the question is, what is the culture that I, as an individual, have grown up in? Social culture affects how we develop those systems in particular. And I can talk about that more effectively, I think, just as my lived experience as a woman. I'm of that weird age where when I grew up, the idea that women had employment opportunities other than teacher, nurse, or none was just outlandish. I remember growing up when my mother, who happened to be a member of the local chapter of NOW, would stand up in different settings and say that it was important for women to have equal pay for equal work, that my friends' mothers were scandalized. And now, yet that phrase we would consider quite a norm. So that's really an example of how culture then informs the system. Culture tells us implicitly what is right and what is wrong, what is acceptable. So Wisconsin, where might we find that structural racism reflected in our systems? Certainly in our education system. We see that, certainly I live in the southeast part of the state where we have perhaps the most diverse population, but we have populations, multicultural populations throughout the state. And some of those of you listening may be in parts of the state where the predominant non-white populations that you live with are Hmong or American Indian. The question really is a simple pause. Are the educational opportunities and outcomes similar regardless of that race or cultural background? And we know in Wisconsin, we have all the data we need. We know that's not true. Employment, we have the same data in Wisconsin that we know is not true. And in fact, it was interesting yesterday when our first speaker talked about the impact on COVID and cancer care. We also have extensive data, which has been collected both on a state level and national level, about how employment and the lack thereof, or employment that puts people at risk of COVID, has really been a burden that has been primarily borne by our fellow residents of color. Housing is another example that's in Wisconsin. Southeast Wisconsin, Milwaukee and Racine in particular, are the two most segregated residential communities in the nation. But when you look at the state statistics, we're not that much different. And interestingly enough, there are plenty of studies, as well as a number of books. I could bore you and give you more books and more articles that have documented how official government policies were actually created to deliberately undermine the Fair Housing Act of 1968. So it's not simply that we are segregated by housing because there were underlying structural implicit biases and people made certain choices unconsciously, but we actually have systems that were created by government actors to actually encourage segregation. Nutrition, transportation, even our freedom of movement and our psychosocial environments, our access to mental health care, our ability to go out to the park and play safely or even live near a park. And I list these things because these are all, as I'm sure you as professionals and folks who live in the oncology space already recognize, these are all categories of social determinants of health. Next slide, please. So what do we talk when we talk about structural racism in culture? We're really just talking about assumptions. So when we talk about the systems we've built in oncology care, we've built systems that assume trust between patient and patient's family and the healthcare professionals. We have built on assumptions that there is actual understanding, not just trust, but there's clear communication, and that's working just fine. We have built our systems based on providers' wisdom and that the provider should control the process. In the time that I've worked and volunteered in oncology, I have seen dramatic change in this attitude. But I can also tell you that last summer I went to the doctor with a friend who was newly diagnosed, and it was clear that the doctor was in charge and dictating the situation. And that was not a function of him not at all being uncaring. It was an assumption that was built into the culture of how he had been trained as a doctor and into the assumptions of how my friend had been trained to act as a patient. We also assume stable environments for patients, but in fact, as COVID has laid bare, not just for people of color, But for so many people in the state of Wisconsin, stable environments are not the given. And many people, and we have massive poverty in rural areas, not just in metropolitan areas, many people have been living from paycheck to paycheck. And oncology care and a cancer diagnosis, the way we provide treatment assumes that there's a stable environment back at home, and there often is not. And we also assume that the personal health of that patient is a priority. But in fact, in many cultures, including the culture of being female, not just a culture that's race or ethnically connected, we have come to understand that that assumption is faulty, and that patients will often make decisions about treatment based on how their treatment and their care will affect the needs of their loved ones. And that's the right-hand category, the reality category. So starting at the bottom, I just mentioned one of the realities. Patients often make decisions based on the well-being of their loved ones and their family, that unit, not just their individual result at the end of the day. The reality is they may live in a traumatic situation. It could be financially traumatic, living hand to mouth or paycheck to paycheck, or it could be that there's actual physical or psychosocial trauma in the home, making the cognitive reality of a cancer diagnosis that much more challenging. The reality is it's not about trusting the provider's wisdom, but being trained to acquiesce to whatever the provider says. We have plenty of examples, and I'm sure many of you do from your own experiences, of confusion rather than understanding, partially just because anytime someone says you've got cancer, as the flip remark goes, if you are told you have cancer and you don't fall over just from the news, you are a cancer survivor. But it really is true that there is so much information that is thrown at you when you're diagnosed with cancer that once someone says the word cancer, you don't understand anymore. And I used to intellectually appreciate that. But a few years ago, I was diagnosed with a precancerous condition, and now I'm being monitored. And I can tell you, after I heard that word, I really nothing much registered. I took the little brochure home and I did what everybody else did. I Googled Dr. Google. But it's really true. No matter what our background, I think it's really rare that you hear the word cancer and all of a sudden confusion becomes your best friend, not understanding what the doctor is saying. And then the reality for people of color is there is generational, multi-generational distrust. And again, the lived experience I can share with you there is not just that we, when we work in oncology, are told that people of color don't trust healthcare, and we're given examples. But for more than a decade, I was a guest lecturer in a health law class at UWM. And in actually a couple of years, I taught it as well. But all that time, whether I was the guest or the instructor, the module I focused on was a basic bioethics module. And that actually had to do with providing some background about how bioethics had developed. And I always started that lecture, and this was a required course. So this class, the lowest number I think were 50, and usually it was more like 70 or 80 people in this lecture hall. But before I started this class, and UWM has a large percentage of its students are non-traditional students, AKA they're well over 22. But every class I would start by asking who had heard of the Tuskegee syphilis experiments. It was extraordinarily rare. So rare that I don't even think it was five times in 12 years that any white student of any age, and these are college students, had ever heard of it. And these are also upperclassmen. This is a course that is required for juniors and seniors. I never, ever had an African American or Black student who didn't know about it at all. So if we are told in academic studies about the different things that have happened, about how populations of color have been treated by the healthcare systems, and intellectually we can say, oh, that's horrible and things are different now. But we should really understand that these are the stories that are told at the kitchen table, even today. Next slide. So as we wrap up, what can we do as we look at the cancer plan and look at the equity chapter and the fact that equity is also woven into every chapter? I think using that plan as a Bible, I guess, as it's intended. If we go to page 5, there are particular things that stuck out to me. There's a statement that says healthy behaviors never happen in a vacuum. And the question that came to my mind is, why is that modified by healthy? Behaviors of all kinds never happen in a vacuum. And that includes race and racism. Structural racism, I have been persuaded over the years, both lived experience, formal education, and looking at data and results of different activities, including looking at social determinants of health, is real. And so the behaviors we use to build our systems incorporate that structure. And how can we reflect on implicit biases? How can we become more aware of them and build systems that have more equitable outcomes? There's a paradox in all of this, actually, from my perspective, and I don't know if you share it, and perhaps we'll learn that in the Q&A. One of the paradoxes I referenced earlier, and that was the story I shared about the book club and the biography of Laura Ingalls Wilder. We have the reality of a shared history, regardless of our race and cultural background in this nation. But we also have the reality of a separate history, a separate lived experience. Some of that's history on a broader cultural level. And again, one of my lived experience lessons actually came from the cancer world. One of the first projects I was involved in when I was at ABCD as a staff member was working with the Wisconsin Pink Shawl Initiative. And you heard from Carol Cameron yesterday. And it was my amazing luck to not only meet the women of the Pink Shawl, but have many of them become friends. But one of the first things we did after the first meeting was try and set a regular meeting schedule so we get certain things done. And we were having a really tough time finding free common time, in particular because one of the key experts was also a faculty member at a local university. And when she identified when she was available, she said, oh, these 2 dates in November are completely open. And most of the women from the Pink Shawl organization said, yeah, I could do that too. I could do that too. And I, very naively and completely wearing my implicit bias and uneducated perspective on my sleeve, said, well, of course those dates are open. That's Thanksgiving and the day after. And Carol, God bless her, and I'm pretty sure it was Carol. I don't know if you're here today, Carol. Very kindly and with a little bit of a grin and a little bit of sadness said, Ginny, not all of us live and mark Thanksgiving in the same way as you do. And that was not in any way implying that American Indian communities do not give thanks, but it was acknowledging quite clearly that they are affected by what Thanksgiving is memorializing very differently than I am, who is primarily an Irish American who's descended from people who came over here in the mid 1800s after a famine. So that was one thing that drew me into the paradox of putting this plan forward. The other thing that came to mind as I was trying to figure out how to close was how we can actually be successful with this plan. If we prioritize those who are most burdened as we build an equitable system for oncology care, let us ask ourselves all the time, how is that going to change our approach? Because it means we're acknowledging right now that we don't have an equitable system. And if we don't currently have an equitable system, we have to be willing to acknowledge that some of the system has to be reconstructed, reflected upon, and that action really must include listening to and learning about the lived experience of those who currently have that inequitable experience. So I suspect that is not as literal a and data-driven presentation as the Cancer Summit is accustomed to having. But I hope that these reflections, as well as the actual information that's in the plan itself, will be a good baseline for continuing these kinds of conversations and challenging each other to figure out how together we can make sure that the cancer burden is not only more equitably experienced, but experienced less by everybody. And I do believe we reserve some time for Q&A and comments, as well as pushback. No, there's no requirement that everybody agree with what has been said.
Ginny, thank you for that thought-provoking discussion, really, because I think you left it so open for people to think about and talk about. And I know that Dr. Mills, in his comments, even said excellent historical perspective to impact and redefine traditional approaches for a new paradigm. I especially appreciate it because, you know, I focus on health behaviors, this idea that it's not healthy behaviors occur in a context, but all behaviors do within a context. So we would love to hear from other people with their questions, their comments for Ginny. And if you put those in the chat box, Beth Bruno will then moderate those.
Great, thank you, Dr. Stolley. So Ginny, we just have a comment here from Regina with the Division of Public Health that she just wanted to thank you for the presentation. The one thing that stuck out was how you describe bias with looking right and left. The description will serve well when trying to describe bias to others in the future with no political viewpoint on that. So thanks again.
Oh, I'm very hopeful. And I think anytime any of us can think of an example that takes bias out of that context, not because we don't want to address that context, but let's be honest, we all live in a world right now where we're not listening to each other. And so that in some way is our big challenge, is how can we get back to listening to each other?
Ginny, Deborah Nevels also wanted to just thank you for the presentation, and that behaviors happen in a vacuum was thank you for that reflection point. That was one to highlight and thank for that. Ginny, one question I had is, as we have organizations from across the state that are on the line, and as you lead an organization in Milwaukee, what kind of, it's hard to help an organization see things in a different way, or, you know, if we are excited about this and we want to help it in line with the cancer plan, do you have any thoughts or suggestions as you kind of reflect on how you've worked with your organization to bring these thoughts and ideas to either a board of directors or your members and participants to really look at making those changes?
Well, sure, I have lots of thoughts, but you know, everybody who knows me knows I go on forever. So let's make it quick. I think that there are a number of tools, but I think one of the things that is particularly helpful to remember is that this is a 10-year cancer plan. That doesn't mean we want to wait till the 10th year to be effective, but we are dealing with issues that are multi-generational. So bringing in a single workshop or having a single speaker or reading a single article is not going to actually seed the change you want. The other thing is, I will do a completely biased commercial for YWCA, and it's not just Southeast Wisconsin. There are 5 YWCAs throughout the state. All of us have different experiences with racial justice programming, and actually we share racial justice programming. A huge part of our work here in Southeast Wisconsin, as well as the Madison-based Southeast Wisconsin, has been established for more than a decade, in fact, close to 2 decades. And some of the other YWCAs have been in that space a little shorter, but are quite comfortable and competent. So if you are looking for resources, whether it's a training or whatnot, we are happy to speak with you. We have some things that are standardized presentations, but for the most part, our first step is consulting you and saying, what is the current culture of your organization? What are you trying to accomplish? And it's not going to be much different than any kind of promoting change. What will be the formula internally for internal champions? Because you can have a consultant or YWCA or anybody come in and do a 5-hour presentation and go away, and nothing will change. The other piece of advice I would simply suggest is that it can't stop at a policy matter. If changing policies without changing practices is window dressing, and it's well-intentioned, but it won't get you where you want to go. So making yourself accountable and creating a process for that accountability, including if it means having an ongoing contract with an outside professional, is very, very helpful. Not different than any other change you might be trying to create in your organization. Oh, and I see somebody's doing a commercial for Unlearning Racism. Thank you. Yes, if you want to go to our website, I don't know if I put it in the, it's simple. It's YWCASEW.org. But you can learn about our racial justice offerings, including public courses, all of which are being delivered remotely and quite frankly are growing dramatically. But similar resources exist if you have a YWCA in your own community. And if you specifically wanted an introduction to personnel there, I'm happy to do that so that you can connect with your own community-based resources.
Ginny, we do have one question that we would love for you to share, maybe your thoughts on the reflection question. How do you engage the most burdened communities in co-creating new systems and structures? If you have any thoughts or that you'd like to share with the members.
Well, one, it starts with don't show up. You know, there's the old joke, I'm the IRS and I'm here to help. And I'll be frank, and I'm not even going to apologize because I know this can potentially offend. I'm a white person. I'm here to help is not helpful in any community of color. So I do think that humility, which is not the same thing as prostrating yourself and saying you're evil, but just, you know, coming in and saying, hey, I have things to learn. I can give you a practical example. We just launched yesterday a career development workshop series called Emerging. And it was a retooling of a project we had done a number of years ago. And we wanted to refigure out how to provide these career development workshops primarily for our existing program participants who are women who are often early career or re-entering the workforce, but often very low income. But before we decided what they needed to know, we just did a couple of surveys and asked them. And although they in fact did want some of the pragmatic skills we intended to provide and that kind of workshop, their number one priority was psychosocial. Their number one priority was, I'm not working, I'm home with kids, I'm being expected to do all these things, I have elder care. And so the first workshop, which debuted yesterday and had 79 registrants, was how to not fall apart when you are in fact falling apart. Now that may seem like the corniest example in the world, but the point was the very people we wanted to offer a workshop to, and we are a team that is primarily a team of color, but not all, was to listen to the customer. I mean, that's actually from, you know, a for-profit business. If you are trying to get people to engage in healthy behaviors to reduce the cancer burden, if you're trying to get them to be treatment compliant, if you're trying to get them to affect their behaviors, then first find out what is motivating their behaviors now. That's co-creation.
Thank you, Ginny. We have time for one more question, and it is kind of along those lines a little bit of, you know, the talk was about racism, but disparities exist in the community where there is little diversity. So today you discussed could apply to other isms, poverty, rural, urban divide. Do you have any thoughts about that kind of reflective point?
I think actually those are very important. I mean, yes, we decided for this morning we wanted to be specific to race, but you know, all of us occupy many spaces at one time. Even YWCA, our mission is to eliminate racism and empower women. So we're working at the intersection of those two realities. I think that the underlying techniques can be very similar. And if you take, I think if we take the poverty issue in particular, we have poverty in the state of Wisconsin as well as great wealth. And that is not limited to urban areas or only rural areas, but we do have false narratives, I guess, and from my perspective, where there is this perception, or at least it's my perception, that the perception is that the poverty is specific to urban areas and almost always only with people of color, which really can create even more burden for those who live in rural or outer suburbs, who actually are struggling financially, because the resources then are either not there, or even if they are there, they're not as prominently provided. So I really think, again, returning to humility, listening to people, but also not trying to, for lack of a better verb, tackle every disparity all at the same time. Poverty is not the same issue as racism, as sexism. An individual may actually be affected by all those isms, which are systems, but do some root cause analysis for the patient population that your facility is serving. What is the common ground and where can you start? And we do often talk in this nation specifically about racism and presume we're talking about Black and brown communities. But for Wisconsinites that are in more of our rural communities or smaller metropolitan areas, the non-white and person of color populations are more likely to be Hmong or American Indian. And I think building relationships with those organizations and those communities is a first step. And I'll go back to Carol Cameron, who was a speaker yesterday. Much of what I have learned and still need to learn, I learned from Carol.
Thank you so much, Ginny. I just want to also, as was put in the chat, that Ginny is going to be joining us for our November webinar along with Dr. Alonzo Walker to continue a little bit of this conversation, but go more into our cancer plan and how can we put it into action, and how can we as a collaborative come together and really move forward these priorities in our health equity chapter. So Ginny, thank you so much for today and for your continued support and guidance as we move forward as a collaborative. Dr. Stolley, I will turn it back over to you to introduce our next speaker.
Great, thank you. And thank you again, Ginny, for that really insightful talk. Our next keynote speaker will actually help us dive a little bit broader and deeper really in our exploration of opportunities to reduce the cancer burden and also advance health equity in Wisconsin. Dr. Young will talk a little bit further on systemic racism, stressors, really root causes that Ginny certainly touched on in her presentation. I've worked a lot with Dr. Young. I have huge, enormous respect for her wisdom, her graciousness, just a really terrific person. Let me tell you a little bit about her before I go on and on. Dr. Young is a medical sociologist, and she is also the director of the Center for Healthy Communities and Research in the Department of Family and Community Medicine at the Medical College of Wisconsin. Her research focuses on the structural determinants of health and their impact on health outcomes, and also racial health disparities and how these disproportionately affect particularly women of color. So we please settle in and listen as you did with Ginny, with ears and hearts open as we begin and continue this exploration. Thank you, Ginny. Thank you, Staci.
Thanks, Melinda. Actually, that I don't mind at all the mistaken identity. I value and respect Ginny quite a bit, and it was really a pleasure listening to her presentation this morning. And thank you also to Beth and Wisconsin Cancer Collaborative for this opportunity to speak with you today. I'm really excited about this presentation. I think it dovetails nicely on what Ginny was speaking about earlier with race and racism and health equity, and the effects on, or the impacts rather, on cancer control. And some of you might, if you were on the call last week for ACS CAN, you might recognize a few of the slides in the presentation today, because it's consistent with some of those same thoughts around race and racism. Next slide, please. So I have three main goals for what I would like to discuss today: to provoke critical thought, to generate questions, and to spark action. Next slide, please. So over the last 7 months, if not longer at this point, sometimes time just sort of blends together, doesn't it? We've experienced a wave of social issues brought to the fore and exacerbated by this global pandemic in which we're all getting through. And earlier this week, I attended and presented at the annual Public Health Association annual conference. And this is a virtual gathering of scientists, clinicians, learners, other professionals, and engaged community members that are all committed to addressing the most pressing health issues faced by the public. And I left this meeting feeling pretty fired up, and I think everybody else at this conference was too, even though it's a virtual meeting. Normally this is a gathering of 15,000 people from around the country in different parts of the world, but you could still feel in all of these sessions how committed everybody is to addressing the needs of the public. And there's a lot of learning points that I got from the conference this year that I think are quite relevant for this presentation and the work that we're doing in cancer prevention and control. So this slide actually highlights the numerous areas in which we see these downstream effects really on in public health on housing, healthcare, and the health of the public. So this includes the environment, poor water access for individuals in Flint, Michigan, the Dakota Access Pipeline and threatening the water supply for the Standing Rock Sioux and other tribes, the rise of evictions during a global pandemic, and calls for social justice by medical students and clinicians, and the ways in which this pandemic is affecting the mental health of people around the world. And I think this is really important because, and you'll see this in the coming slides, while my focus is on healthcare, that's my area of interest and expertise, all of these areas are entangled, if you will. So issues of housing, issues of other things tied to social justice, all of that is relevant for the work that we're doing in cancer prevention. Next slide, please. I understand that health equity is something we've been talking about over the last couple of days, and you've seen the definitions and heard this come from multiple speakers, but I believe that repetition is a good thing. It helps us to learn and drive home concepts. And one thing that I really like about this graphic comes from the Robert Wood Johnson Foundation, is that it focuses on what happens when everybody is given the same tool, if you will. And I think this can also happen with policy, making assumptions about what affects everybody and is everyone receiving the same benefits. So the definition, as we've been hearing, is that everyone has a fair and just opportunity to be as healthy as possible. And this really has to do with improving the average health for everyone and addressing the avoidable inequalities in health. And this requires removing obstacles such as poverty, discrimination, and their consequences, including powerlessness and lack of access to good jobs with fair pay, quality education and housing, safe environments, and healthcare. So the question that I think comes to mind with this for me is, what are we doing to ensure that obstacles are removed from people being able to enjoy optimal health and reaching their full potential? Next slide, please. And one thing I'd like to leave the group with, at least at the beginning of this talk, is a reflection question or comment, if you will. And that is, my work includes health equity because. So we have this working definition of health equity, but think about your work along this continuum. And how do you think about the body of work and what you do now or in the future and the degree of impact? So if you think about the prior graphic and these particular points, I don't discriminate against anyone. That's important. It's not putting a value judgment on any of these as greater or less than the other, but I don't discriminate against anyone might be the belief that everyone should have a bike or should have a means of transportation. I serve vulnerable populations impacted by disparities. So I make sure that everyone gets a bike, gets the same bike perhaps. And I plan my work in a way that ensures it addresses the factors leading to health inequities, might be seen more as maybe not everyone can use the same size bike. My goal is to ensure and plan that everyone has the right means of getting from point A to point B. And maybe that's not the same size bike. Maybe everyone should have something different. So my work is to ensure that everyone has what they need in order to thrive. So I would encourage all of us to think about our work in that way. And what are we marching ourselves towards? Next slide, please. This is also consistent with other information that's been shared throughout the last couple of days, but as we know, these disparities in health and healthcare have persisted and in some cases widened over time. And the Kaiser Family Foundation released a report this past June after completing an analysis of a variety of nationally representative data sets and looked at 27 different measures that covered health status, including birth risks and outcomes, chronic health conditions such as breast, lung, and colorectal cancer, and smoking, obesity, and substance use, and found, unfortunately, that there were racial and ethnic minority groups that still were disproportionately faring worse over time compared to white individuals across these different measures. And that includes primarily Black and American Indian or Alaska Native individuals. And what I think is really striking here, and Ginny spoke to this as well, is what happens when racism and discrimination actually cut across all of these outcomes. And that's why, and you'll hear me mention this more than once, the importance of realizing that when we're trying to seek changes in health outcomes over time, it very well means needing to address some of these other areas, needing to address economic stability, neighborhood environment, community context, food access, education, and the ways in which these things work together, either for one's benefit or perhaps unfortunately to a community's detriment when any of these areas are compromised. And so the question to ponder here is, does addressing health equity for cancer differ markedly than health equity for other chronic conditions? And I would argue no, that when we go upstream enough, and this is me talking as a sociologist, when we go upstream enough, the work has downstream effects across a multitude of health conditions. And this should really only encourage us even more to work across the aisle with folks that are working in different areas, because ultimately we're all seeking the same downstream effects. Next slide, please. So Ginny discussed very beautifully, I think, this history of racism in the United States. And of course, we see this globally as well, but why addressing it is so important for our collective work. And what I argue here in this slide is that these other systems are also effective. So when we talk about institutional racism and the policies and practices within organizations and institutions, or systemic racism, that is the racism that is ongoing racial inequalities maintained by society, that permeates all of these systems that are here. So that permeates housing and criminal justice and public health and education and banking. And I would argue these are the same systems that would probably see themselves, and I say this as a collective, ourselves, but the individuals that work within these systems probably see themselves as treating everybody fairly, and that we don't have that problem within, healthcare. We don't see that problem in housing. Everyone gets treated the same. Everyone has the same opportunities, and yet we see in our data and outcomes that is not true. We certainly see that in the data tied to health outcomes. So the point in this slide is to one, state that these issues with racism permeate all of these, it permeates all of these areas, and these institutions really are quite tied to each other. So this is why when we're working in health and healthcare, we need to be very invested in what's happening in housing access or issues of economic inequality. And I think COVID is bringing a lot of that to bear. All of these things are sort of bubbling up all at the same time. Just recently, the New York Times had a pullout section on out of work in America. And it was just this really sobering piece of journalism that talked about the woes of individuals across the country as they're seeking jobs, food for their families. And I couldn't help but read this and think, all of these are individuals whose health is unavoidably affected by this. And we're all going to see these ripple effects. And it's important for us to be very invested in that. Next slide, please. This slide actually represents, this is a very simplified version of a conceptual framework that my colleague, Dr. Kirsten Beyer at MCW, is a geographer and just a wonderful, wonderful colleague to work with, that we had developed in order to document some explanatory pathways between racial segregation and breast cancer survival. And it's a very complex looking conceptual framework, so that's why I don't have the whole thing copied here. I'm happy to share it because we recently published a book chapter on this. But the point in raising it here is that there are several pathways that we're examining in a current NIH-funded study looking at individual experiences of Black, Hispanic, and white women and their neighborhood of residence over time and how that might contribute to their breast cancer survival. And some of the things we're looking at have to do with the fundamental determinants of health. That could be biology, geographic origins of their families, and experiences with racism and societal institutions. But how that contributes to, one, social status, like their individual socioeconomic status, their neighborhood of residence, where they are able to live or where they've lived over the course of the last number of years. And then looking specifically at, excuse me, at different pathways such as stressors. What does that mean for experience with local stressors and the physical environment or historical trauma or generational trauma, social resources, access to resources such as housing quality or healthcare quality, healthcare access, and knowledge and information that they have or are able to attain about healthcare and their healthcare needs. And then following from that is the responses. What are the behavioral responses to that? The coping mechanisms, the psychological responses, not just the physiological responses, although we're examining that as well, some of the physiological responses that have to do, or that are tied to treatment that they've received for breast cancer. And ultimately what we'd like to be able to do is to draw some conclusions about what does this mean for survival disparities over time and the appropriate use of different types of treatment or survival outcomes, duration of survival or recurrence and quality of life. So we're really building in all of these different areas that I was speaking to earlier as structural determinants, social determinants of health, and what that means for individuals participating in the study that we have. Next slide, please. So what I'd like to speak to is a couple of different areas that are tied to policy. And I think it's important to talk about when policy leads to poor outcomes. And I think what's critical with policy is not only that we can have policies and programs that are beneficial, but also we have historical evidence when that's not been the case. So this particular, what I have on the slide here is an 85-mile stretch that was known since the 1980s as Cancer Alley. And this is a stretch between Baton Rouge and New Orleans, for those of you that are familiar with Southern Louisiana. Also the area that was recently hit by yet another hurricane. And this area, this stretch, contains roughly 150 petrochemical plants that line the bank of the Mississippi River. And this area is also, the residents of this area are predominantly Black. And according to the EPA's 2014 National Air Toxics Assessment, their risk of these individuals, these residents, of getting cancer from air pollution is 95% higher than most Americans. And unfortunately, this is also the same group that is disproportionately now dying from coronavirus. And at one point back in April, St. John the Baptist Parish, and in New Orleans, they refer to their counties are called parishes. They had the nation's highest per capita COVID death rate. And despite the fact that African Americans only account for a third of the population in the state, they are accounting for 55% of COVID deaths. So these are all overlapping areas of concern. So where we see the higher cancer rates, now we're also seeing some of these higher COVID death rates. And what's notable here, and I tie it to policy because the chemical plants were relying intentionally on loose zoning, cheap land, and convenient access to a major shipping corridor, and the ability to take advantage of air pollution standards that are quite the loosest that EPA was allowing. And so this is problematic. Obviously, as we know, the ways in which this can affect the health outcomes for individuals over time and who is disproportionately affected by these policies. Next slide, please. So the other example I would give is housing policy, and Ginny touched on this a little bit earlier, and how housing policy affects cancer outcomes. So this is a 1938, and I realize it's not very big, you don't need to see the details of it, the colors of it are what are most important. This is a 1938 map of Milwaukee County that was created for a federal agency, and assessors actually shaded 19 areas red. And the goal was to mark them as quote unquote hazardous, a hazardous risk for home loans or insurance. And so a set of forms actually accompanied this map evaluating each neighborhood. And some of these neighborhoods in red were deemed a risk because of problems like polluted water or lack of modern sewers. But each form also assessed race and ethnicity. And I realize there are people from around the state on this call, so I don't want to make assumptions about people's familiarity with the geographic layout of Milwaukee County. But the red areas are primarily at this time had high concentrations of African Americans, Latinos, and Native Americans. And at that time, these were the newest residents of Milwaukee who had largely arrived during the Great Migration as well as World War II. And they actually replaced and settled into the city's inner core area and replaced descendants of the original German and Irish immigrants. And what's notable here is between 1960 and 1968, officials tore down about 7,500 homes in Milwaukee's urban core in order to facilitate quote unquote urban renewal projects. And what I think is telling over time is that if you look at this map and compare it to other maps of cancer incidence and mortality in Milwaukee County, there is a direct overlap. The heat map, if you will, of the highest incidence is the same as this map for the areas in red. And it's a little bit trickier to tell on the slide, but there is a slice of white that cuts through a portion of the red colored counties, and that's the interstate, that's I-43. And that was also in an effort towards urban renewal. And what that did was it effectively cut through, this is the 7,500 homes that were torn down, it effectively cut through the heart of the African-American community. And there are family members, my own parents, we're not far removed from this, that talk very fondly of what that neighborhood meant, and also what it meant to have that bulldozed, and what does it mean for any group of people over time. This is not just Milwaukee, this is a general statement. What does it mean when policy in effect is intended to remove you or to erase you? What does that do to generational memory or memory over time across different families? So these conversations at the kitchen table that were mentioned earlier, these are the things that families talk about. And at the same time, these are areas of Milwaukee that are also losing healthcare. They're losing access to hospitals. Hospitals have left these areas. There's maybe one, I think, still major hospital located in the actual city of Milwaukee. So again, we see these overlaps. So these policies are quite relevant to the work that all of us are doing. Next slide, please. So what I'd like to focus on now is reimagining policy change. So we've got a little bit of background on issues with race and racism and policies that have been ineffective in health outcomes, but I'd like to talk a little bit about policy change and how that's relevant for our work. Next slide, please. So something to know about me is I love weightlifting. That's just something I enjoy. I'm not a runner, but I do love to lift weights. I find it just very gratifying. And of course, it's good for health. And I chose this slide as a bit of an analogy because when you lift weights, excuse me, and you're lifting a barbell, you add weight to the bar with plates, different weighted plates. And you can adjust the weight. You can take plates off, remove plates. Generally, the bigger plates are heavier, and then the smaller plates weigh less. Well, when my trainer works with me, he knows what my max weight is at any given time. So if I approach the bar and I can look at the bar and tell how much weight is on there with the plates, I can look and say, well, wait a minute, Ryan, there's 300 pounds of weight on this bar. I can't lift that bar. His response might be, oh, okay, well, yes, I realize that. Let me help you with that. Let me take off a small plate on each end. And the total of those plates might be 5 pounds. I'd say, well, that doesn't help me very much. You've only taken off a small amount of weight. And he might argue, well, no, I helped. I took off 2 plates. You should be able to lift that. Well, the problem is that it does not meet my needs for what I need to do in order to lift that bar. If I know my max is 250, taking off 5 pounds of weight from a 300 pound bar does not help me. And I would argue there's some comparison there to policy change. Sometimes what we think we're doing something really monumental and important, and it could be, it helps a little bit, but maybe we've only taken off a couple of pounds off of the bar. And what a lot of communities might struggle with is the fact that we've not taken off the heavy plate. We've not removed the big plates that are needed. And maybe the big plates are things that are tied to economic inequality or issues with structural racism. But instead, we're taking off some of the smaller plates and wondering why that bar is still not a bar that someone can lift. Next slide, please. So what do we need to do in order to make some of that weight a little bit lighter? So this is an article that actually came out from the New England Journal of Medicine in 2015. It's a case study of a 60-year-old uninsured Black woman who came to the emergency department of a Chicago hospital with a breast lump. And she was discharged without any diagnostic testing or planned follow-up. But this lump persisted, and she obtained a mammogram, which revealed a potential breast cancer. And as such, she was referred to a general surgeon at the time, or excuse me, at the same hospital, the same community hospital, who had recommended a mastectomy. She was not informed of her cancer's stage or referred to an oncologist. However, she was contacted by a navigator from the Metropolitan Chicago Breast Cancer Task Force, who reviewed abnormal mammograms and guided this woman to treatment. And this person referred her to a surgical oncologist at an academic medical center, where she was informed that she had stage 3 infiltrating ductal carcinoma and that a mastectomy was unnecessary. And what makes this case stand out is that where she received her care initially was not one of Chicago's designated cancer centers. Only 2 of those 12 are even on Chicago's predominantly Black South Side. So where she received her care, there were no mammography specialists. And also, these hospitals were not equipped to perform needle biopsy for suspicious breast masses, which is standard of care. And hospitals serving minority neighborhoods often face financial constraints that limit their ability to deliver these services. So a task force was formed in 2008 as a result of community concern about screening and treatment disparities among Black and white women. And this task force initiated quality improvement efforts and assigned navigators to under-resourced hospitals that had the cancer center designation. And so this was designed to disrupt barriers to care. So the underlying issue here with clinical resource allocation is that oftentimes that's rooted in some of these issues with structural racism, which led to neighborhood disinvestment. And clinically, this becomes operationalized with resource allocation and availability, or lack thereof, of specialists. So the authors here proposed 3 critical strategies to address this in healthcare. One is clinicians making the invisible visible. So measuring variation in screening, diagnosis, and treatment among practices, measuring quality outcomes according to patient self-reported race, gender, and insurance. And where there's variation, there's opportunity for improvement. Two, to engage the community. So having forums to gather input on healthcare experiences, sharing data at community meetings, and synthesizing these into clear talking points for the community. And finally, making systemic changes. So strategies that go beyond healthcare. And we've been talking about this throughout the summit. The need for equity and other social systems affects health outcomes. So clinicians can become active in efforts to promote better healthcare and to end poverty and work against structural racism. Next slide, please. The other recommendation here, I think policy that's tied to healthcare, is the health workforce and strengthening and maintaining the workforce. So the American Association for Cancer Research recently issued a disparities progress report this year, and it's an excellent document to review. And the authors discussed the role of science-based public policy. So for example, regulating tobacco products and increased research funding. But interestingly, they also pointed to a lack of diversity in researchers, physicians, and healthcare workers as a big factor contributing to cancer health disparities, as stereotyping and systemic racism continues unchallenged or becomes more ingrained in the absence of diversity. So this photo is actually part of an opinion piece that was written by a Black female physician earlier this year on her decision to leave academic medicine. And this had a huge ripple effect across academic circles because she was one of few in her clinical field. So her choice to leave was seen as really sad and unfortunate and problematic, because the number of physicians in racial minority groups in medicine, and I would argue specifically within oncology, has only marginally grown in the last 20 years. So the AACR is sort of calling this out and saying, if we need, in order to address these disparities over time, we have to be invested in the workforce and in retaining individuals in the workforce, which is why I call out this example with this, this physician, Dr. Blackstock. It's not enough to get folks in, we have to make sure people stay in the workforce. Next slide, please. The next is ensuring we have a safety net of coverage that protects individuals and families. So this is really tied to ensuring that people have access to all forms of healthcare, including safety net care. So people of color would likely experience the largest coverage losses if ACA coverage options were eliminated. And since now, certainly without federal subsidies, many people would not be able to afford private coverage. But unfortunately, since people of color experience the largest gains in coverage under ACA compared to their white counterparts, they would also likely experience larger coverage losses if these were eliminated. So our efforts to ensure that there is a safety net for individuals around the country that need healthcare is critical, especially as we're talking about cancer prevention and screenings and ongoing treatment. And Dr. Richardson spoke about this yesterday. Next slide, please. So I'll need to go through these next two a little bit quicker. But health in all policies, I wanted to highlight because this is a collaborative approach to improving the health of all people by incorporating health considerations into decision-making across sectors and policy areas. So this identifies how decisions or policies in multiple sectors affect health. And this has been promoted by the Centers for Disease Control and Prevention and the American Public Health Association and implemented across the United States. There's not one formula or right way to implement health in all policies approach. It depends really on the needs, resources, and key partners in various areas. But the key elements that are vital to success are that it promotes health, equity, and sustainability through specific policies and programs, and embedding this into decision-making so that healthy public policy is the normal way of doing business. That it supports intersectoral collaboration, including agencies that may not typically be considered quote unquote health related, so perhaps businesses, for example, that it benefits multiple partners. So health in all policies is built on this idea of co-benefits and that there are wins all around. This can require some negotiation though, and learning about others' priorities and not assuming that we share those equally. The importance of engaging stakeholders, and that includes community members, policy experts, advocates, and funders. So having robust engagement is essential to garner support. And finally, creating structural or procedural changes. So maintaining structures to sustain collaboration over time is critical. So when we do any of this work, it's a marathon, not a sprint, right? So it's important to make sure that this is work we're committed to over time. Next slide, please. I wanted to give a quick example of something that I think is tied to health and all policies, and that's the Build Health Challenge. So Build is a national program designed to support partnerships between community-based organizations, health departments, and hospital and health systems working to address root causes of chronic disease. So this was actually developed as a response to national and ongoing health disparities. And this was formed among the Colorado Health Foundation, Kresge Foundation, and Robert Wood Johnson Foundation about 5 years ago. And a current recipient, and I think so far the only recipient in Wisconsin of funding from the Build Health Challenge is the Sherman Park collaboration in Milwaukee, focused on community resilience. So with Build, there are some key principles that I think we can also consider for our work. One is that work towards health equity and addressing disparities should be bold. So partnerships that aspire towards a fundamental shift beyond short-term, programmatic work and towards longer-term influences over policy, regulation, and systems level change. That the work is upstream, and it's partnerships that focus on the social, environmental, and economic factors that have the greatest influence on the health of a community, rather than only on access or care delivery. That the work is integrated and partnerships that align the practices and perspectives of communities, health systems, and public health under a shared vision, establishing new roles while continuing to draw upon the strengths of each partner. That the work is local and partnerships that engage neighborhood residents and community leaders as key voices and thought leaders throughout the work. And finally, that it's data-driven. And I really, really appreciate Ginny's point about data is not a synonym for evidence. So how we draw upon the lived experience and the work of community residents, those that have lived experience. So that includes clinical and community sources as a tool to identify key needs and measure meaningful change. Next slide, please. So I'm actually going to leave us rather with the same self-reflection that I started with on our work, including health equity. So I hope I've left you with some ideas for how you can incorporate this further into your work and to consider again, now that we've talked a little bit more about health equity, policies at different levels, how that affects health outcome, and what might be other policy or elements in policy consideration moving forward. Again, the work that we're doing, is it about ensuring that we're not discriminating against anyone, that we're serving vulnerable populations, or is it about planning our work in a way that it ensures that it addresses the factors leading to health inequities? And I would argue that the costs, there are costs to action, of course, but there are extreme benefits, and we need big ideas and policies and actions to eliminate the root causes and challenge the root causes of health inequities, and we all benefit when this happens. Next slide is my thank you. And I really appreciate this time with you today. And I would welcome, if there's time, I hope I didn't go over time, I would welcome any comments, feedback, or questions.
Dr. Young, thank you so much for that. And I'm not going to take much time in my comments because there were a number of comments and questions for you, and I want to leave enough time for those. So Beth, if you'd like to read from the chat, that would be awesome. Thank you.
Sounds great. Thank you, Dr. Young. I'm going to just start with a question that was asked. As a sociologist, could you speak about the best ideas to improving diverse accrual in clinical trials?
Oh, that's an excellent question. And as we know, that is definitely an issue. Well, we're seeing that now, I think, also with COVID and what it's going to mean for ensuring that we've got folks that are at some point willing to participate in vaccination trials, or when a vaccine becomes available. I think this goes back also to what Ginny was talking about. This goes back to forming and sustaining deep community relationships. We cannot underestimate the value of people trusting the system in which these policies and recommendations are coming from. It's deeply rooted. If folks are not trusting, then they're not going to want to engage in clinical trials or participate. Many times, I think, the participation in these areas can come from either one, people's own personal experiences or experiences of a family member and wanting to address those and as such participate or encourage others to participate. But also it comes from trusting the person that's asking, or going to communities and talking about the availability of trials and what that means. People have to understand what it means, what is being asked, and the benefits, but folks have to trust the person that is the messenger. And I think there's real meaning, there's a lot that can come from investing in those relationships. So spending time in community settings and talking about what trials are, what they mean, and what the benefits are for an individual, but for the community at large. I do think at our core, a lot of times people want to do things that are for the good of the community and for the good of the public. But we absolutely have to invest in some of those relationships in order to talk meaningfully about what that is and what it means for people to be invested over time. And to also be willing to answer the questions, because folks don't always know. I mean, if you ask someone on the street about clinical trials, people may have knowledge about that or not as much. So being able to speak very clearly about what that is and what the benefits are. Excuse me.
Great, thank
question.
you so much. Another one came in about Medicaid expansion and as a tool for improving cancer health equity. Could you share some thoughts maybe on Medicaid expansion in Wisconsin and maybe that impact it would have on cancer health equity?
Well, I definitely think, and my other hat that I wear actually is as a board member for the Wisconsin Association of Free and Charitable Clinics. And I'm a faculty advisor for a free clinic in Milwaukee. And I absolutely think that the ripple effect of people not being adequately covered by Medicaid, we're seeing that in our safety net system in Wisconsin. So I think it's important to advocate for any policies that ensure that people have adequate coverage. So for those that are childless adults, the means by which we're able to cover those folks through Medicaid, as we know, are limited. And we see that now in other safety net clinics around the state, some of whom have to close because of COVID. So the pressure that it puts on other safety net clinics is rather substantive. So I do think that we see that in our safety net clinics, but the importance, I think, there is ensuring that people have access to screening. You know, what happens if someone comes to a safety net clinic and something might be more advanced because they've not been able to get something checked out. Not everyone is able to get a colonoscopy or a mammogram because they just don't have the coverage for it. So I think it's important to advocate for that. And for those that are in the free clinic setting, ensuring that there are services we're able to provide or to refer to other settings where they can get the appropriate screening and follow-up care.
Great. Thank you so much, Dr. Young. There is a lot of appreciation for your presentation today in the chat. So a wonderful presentation. People are very excited about the work and just really enjoyed listening to your presentation this morning. So thank you again.
Thank you, Beth.
I will turn it over to Dr. Stolley to move us forward in the agenda.
Okay, so it looks like it's time. I'm almost launching into Carol Burnett's song. I'm so sad. It's so sorry about that, folks, but I came upon it on TV recently, and so I watched Carol Burnett. Anyway, it's time to bring the Wisconsin Cancer Summit to a close. I do hope, I think we all hope that we all leverage all the tremendous information, conversation, connections that we achieved over the past 2 days virtually. I think let's give the staff a huge hand for pulling off an amazingly successful summit. Think about all the resources we have, pursue equity in all that you do, and let's use the plan, get it into action, and don't forget the webinars that we have each month that provide additional support. And remember, network. I mean, Zoom has and virtual connections have allowed us to network in ways that we couldn't before. So a thank you to the speakers, participants. I already thanked the staff, but we'll thank them again. And hopefully, and this sort of makes me think of when we celebrate Passover in my family next year in Israel. Let's hope next year in person in the Dells. If not, we know how to do it. So thank you, and I hope to see you in the future in webinars. And have a wonderful day, everyone.